So when our patients come for the first time, I have many potentially different options to consider. So often the first thing I do is look at the patient. So a patient that is asymptomatic and doing very well tells me that irrespective of what I see on the scan, I have to remember that, because anything I do to that patient will cause some symptoms. So in a patient that's completely asymptomatic and feeling great, to take them to the operating room or to take them, for example, to try some very strong chemotherapy, that's going to cause a lot of side effects and potentially some harm. So the ability to see how well the patient is doing, sort of their performance status, is critical. And then the next thing is their scans. So for example, in any patient with local disease or potentially locally advanced disease that we believe is resectable, in that healthy patient, we have to consider surgery, because surgery is the only potentially curative option for those patients. So certainly in a localized patient or in a localized tumor, we at the very least should be talking to surgeons to say, should this come out? Having said that, our disease is such that sometimes there are very small incidental tumors that can be actually just watched. So particularly in patients, for example, that may be elderly, if they have a very small pancreatic neuroendocrine tumor, our approach is often to watch that. Now, how small, that's a matter of controversy. In general, less than 1.5 centimeters, that is asymptomatic, non-hormone secreting, our data suggests could be watched carefully in the beginning every couple of months, but many of those tumors in our series actually didn't grow at all, which is great. So there is an option, for example, in those type of patients to watch. But obviously in a patient who's much younger, where we're finding this, we don't yet know the trajectory of that particular tumor. So in those patients, surgery should certainly be considered. In the metastatic setting, many patients would be considered for what we call cytoreductive or debulking surgery. And that's really based for two reasons. In the setting of patients that have hormone-secreting cancers, often, again, those tumors can be debilitating because the hormones themselves can cause a major quality of life issue for the patients. So in patients that have resectable disease that are hormone secreting, our bias is to consider surgical approach. In patients with unresectable disease that are hormone secreting, we often try a liver-directed therapy if most of the disease is there, again, to try to decrease the burden of disease to make those patients live longer, or live better, I should say. When to decide on regional versus systemic therapy in unresectable disease is a matter of controversy as well. But in general, in patients that have a lot of extrahepatic disease or disease outside the liver, we would consider a systemic approach. Whereas in patients that have predominantly liver-only disease, a regional therapy is appropriate. Having said that, with a lot of burden of disease, often embolization could be dangerous. So we have to be careful. Again, this is a multidisciplinary approach in discussing with interventional radiologists and with medical oncologists the best approach for that particular patient based on their burden of disease. Pancreatic neuroendocrine tumors can be treated with surgical debulking. Having said that, in patients with a primary pancreatic neuroendocrine tumor, for example, in the head of the pancreas, that would require a Whipple. So in patients that are undergoing a Whipple procedure, we have to be careful in ensuring that it's truly only localized disease. If they have evidence of metastatic disease to the liver already, it can be done. It just needs to be done with caution, because therapies down the line may be affected by the decision to do that Whipple. So what that means is, for example, in some patients that have undergone Whipple, if we decide later on to do regional therapies with embolizations, they actually have almost 20 to 30% risk of the development of hepatic abscesses. The morbidity of that is quite high. And in our series, actually, once you had hepatic abscesses, there was actually a 3% mortality rate. So it's a big deal. So we are very careful and reticent to put patients through a Whipple procedure in the setting of metastatic disease. It can and should be done in certain circumstances, but we have to be aware that this is a potentially serious side effect that they may have to consider in the future.